Engagement is a crucial aspect of providing care for patients struggling with substance use. RAAM clinicians care for a diverse community of patients who come from a variety of contexts and life situations. We've invited 3 RAAM clinicians to speak about their experiences in engaging patients from the very first visit and along the treatment journey.
Given that the clients that I see, patients that I see, they have not had any experience or connecting with any care provider about their substance use. So for me, a successful engagement is when I can determine why and how somebody got to be where they are with me at that point, and what priority brought them that day. And just being able to establish the rapport that they feel safe and they feel that they can honestly let me know what they're hoping to accomplish. And at the end of the assessment, I often ask that question, did I meet your priorities today, or what can we do? And just seeing that openness with the patient from the time they come to the time they leave, to me that's a successful engagement.
I think that it's true for the people that we're seeing. It might be the first time they're ever connecting or talking to somebody about their use of substance in a more sort of formal way, or even considering, any of the various treatments or anything like that. So that's really huge. And so I guess building that trust so that people feel comfortable to do that.
Various ways to look at engagement. From my perspective, you can look at it from the team model, and I think that depends on what kind of team each RAAM clinic has set up. But we're lucky enough that we have peer support worker who's there, in the waiting room, engaging patients on more of an informal kind of way. So creating a welcoming atmosphere in the waiting area. Peer support is pretty key for that. Having someone at the front desk, a receptionist who has an understanding of what these people are going through and a friendly face, because they'll often engage with that first line of your clinic more often than they would with me. So that's, I think, number one, is creating that kind of welcoming environment in the waiting room and with the staff of the whole team. For myself as a physician, just entering in the engagement with an understanding, or try to understand where they're coming from. So more trauma-informed kind of approach. And then for me, my style, and everyone's got a different style. I don't take the paternalistic approach at all. I think sometimes that can push people away. So try and engage my patients with in the decision-making process of any kind of treatment plan that they want to follow through with. So, within the realm of risk and whatnot as far as prescribing practices, but still just trying to have them involved in any sort of decision. So that's a big approach of mine. And then for me to understand if there's been good engagement on that first visit, there's a lot of just subtle things as far as body language, eye contact. A lot of the Indigenous people aren't comfortable with a lot of eye contact, but if they start towards the end of even a 20 or 30 minute session, start to meet your eyes a bit more, I think is a real good sign. Body language, you can kind of get clues as to how interested they are in making a follow-up appointment. So I'll engage with them. When do you think is a good time for you to come back? And then you can kind of get subtle clues as to their level of excitement about coming back.
My background is really in doing a lot of outreach here in Toronto on the streets and drop-ins and shelters. So we've added a real sort of outreach component as well to our RAAM, so that if people have someone who might be interested, but they're nervous to even come into our space, one of the community workers can go out and meet them and start to develop that relationship, and hopefully with a view to bringing them in to meet the nurse practitioner, or just to have that first conversation. So we're trying to really engage with people where they're at and break down as many barriers as possible. I think people have had huge barriers and a lot of systemic racism and discrimination as Indigenous people encountering the healthcare system or any systems. Knowing that the staff are coming from Indigenous organization and that they can have access to cultural services there, they know that there's cultural safety, that people were coming with an understanding of many of the issues historically and ongoing that people are facing. So in terms of intergenerational trauma, residential schools, so people know that the organization brings that. So staff coming from that organization are bringing that perspective, so that helps a lot. Many of our staff are Indigenous, or mixed heritage like myself, so that helps as well. So people feel that they can make that connection in a way that is safe, right? And begin to build that trust and talk about those really maybe challenging issues around substance use.
It doesn't matter what kind of population one is having. I think it's very important to have apply a trauma-informed universal precaution with everyone until you get to know the person. And this goes from, how you approach them in the waiting room. How do you shake their hand? Do you nod? Do you not? So really just having a universal approach where you extend openness unless it is, for example, don't assume that you can shake someone's hand or extend your hand out. Just watch how the body language is. Some people, you call their name and they look at you, you know that it is them, but they won't even acknowledge that, yeah, that is me. Or some people are, oh yeah, that is me. So all of those things, I think, are important, and there are various, cultural and social reasons that people present like that. But to have an openness that people come from different backgrounds, there are different experiences that, either inform how they are presenting here, or even cultural norms that inform how they manifest when they're in the public. I have seen a lot of patients, especially from Indigenous communities, who come and say, I do not use substances. I don't use and I don't even deal. I was just in the wrong place. I got charged and now I'm being told to come here. So how do you start to engage that person? And how do you support that kind of person? There are other people who say, I do not use substances. My child uses or my parent uses, and I had them on me because I'm the one who gets it for them. So you get to understand all these social factors that could be contributing to the issues that are going on, not particularly substances. And even for those who use substances, why are they using and what role does that substance play in their life? Because with that understanding, then you get to understand first, how do they find out about this clinic? Maybe it's mandated, maybe their family member, maybe they found it in the news. But why did they make a decision to come? What goal do they have? And when you determine that, then you can engage from a patient-centered perspective of what you can help them accomplish going that forward.
The challenge of kind of bridging that barrier between what my life is compared to what most of my patients' lives are like. And I think that's kind of what you were getting at as far as the engagement. I'm a white male, privileged white male like you, right? So I think a useful exercise is to just take a couple seconds before your interaction and just think about where that patient or client slept last night, how that patient got to your clinic. Just those two simple questions, just to ground yourself in their reality. I think that is a good way to start, just by understanding what their life is like. And you don't even have to have the answers, but you can usually kind of, have an idea, and then that'll come up in conversation. I mean, a lot of these people are impoverished, living in a shelter, using transit if they can, or walking, or getting a ride from a friend. So even them getting to that appointment in and of itself can be a challenge. And we forget about that sometimes when we have our own vehicles, we have transport, we have a warm house with family that's it's a crowded house with all the family, which sometimes happens, right? So I think that's a good exercise to do if you feel like you're, not fully understanding the struggles of the people you're serving. When you deal with no shows and trying to balance some patient accountability, which also is an important part of them getting better, but also understanding that the number of barriers they have to fulfilling a treatment plan or even making it into your appointment are significant.
That's why we added a big outreach component, right? Knowing that not being able to physically get to the appointment, there could be many, many reasons, right? Even just lack of access to transportation, not having a regular place to stay, precarious housing, no housing, all of the issues that might be coming up. We want to sort of be able to reach out as much as possible to go to the person and say, hey, what's going on? Can we give you some, transit, even like some practical things to help you get from point A to point B to come and see us. And that's gone a long way to, breaking down some of those barriers to getting, and even sometimes the community workers have gone out a few times and seen someone and they're still kind of like feeling a little nervous or anxious about coming in, but then finally it's like they either just show up on their own or they come in and they have their first conversation with our nurse practitioner, which is amazing, right? So I think creating those opportunities, or as many opportunities as possible to sort of engage, outside of the expectation of people physically getting into the building has been really helpful in us being able to connect with people who might not otherwise come in.
Basic reinforcement of life skills is something I didn't think I'd ever really be doing in medicine, but
yeah, here you are.
It builds relationships that way too, right?
Yeah.
Because it focuses on a simple goal. I mean, you want to get into the motivational interviewing, SMART goal type approach. Take that approach right down to the very basics. I mean, if they can't do something as simple as, making a calendar, which some of them can't, but that's a simple goal, and hopefully they develop that skill, and then you build on that. So.
And some of the techniques that I do in clinic during that initial visit is I try to help patients help me create kind of a system that is going to work for them. Because I find a lot of the patients that come to us are those who are marginalized and high risk, they're homeless, they may not have a phone, they don't have an address or a contact that you can trace them. So it's how can I create a system for them that will work? For example, what are the days looking at if they're living at a shelter and there are activities that they're required to do there, or the times that they go for lunches? Can I then connect the appointment to some of those things that they will remember naturally? For example, if you go every Wednesday to this drop-in for lunch or whatever, can you then remember when you're going there, that is also the time you come to see Irene? And really working with the physicians to know that we have a collaboration that if they're not here, I can do that assessment and they can feel safe to have a prescription prepared when I tell them that I've done that assessment. So really working as a team to support one another and to ensure that the patient are supported as well. And the other thing in the initial appointment is for me, and I learned this from a physician who presented at one of the conferences through OHTN, which kind of solidified what I already knew, I couldn't put it to word, that to treat, you need trust. And to build trust, patients need to feel safe. And for them to feel safe, they need to be heard. And so before we can plan all of this, I want to understand who is this person and what matters to them. Because maybe the lunch cannot even, having lunch cannot compare to my expectation of them coming to clinic. What is it that is so important to them, and how can I narrow my expectations towards something that is meaningful?
Worked with someone who had been having a really hard time getting to sort of any kind of conversation about their substance use, although they had been saying that they wanted to. So we had one of the community workers meet with her and bring her, she was agreeable to come with this worker. She knew the worker, she felt safe with her. She came in to see our nurse practitioner, and it was great. It took a few conversations with the NP till she felt comfortable to, try some medication with this, and the community worker kept engaging her in between appointments and helping her to make sure she could get to the appointments, had transit, and was able to, and really kept that connection and working very much as a team, to your point, Irene. And then the community worker also did a lot of practical things like helping her find housing and doing a lot of those other pieces to create more stability in her life. And so that's been we're a very recent program, but it's been one of our, I think, great successes. She's continued with her treatment and is housed and doing really well.
I think of two. One was someone who is set up to do well, I think, and was fairly straightforward case as far as comorbidities, mostly just opiate use disorder with some cocaine use. But the challenge with this one was that he was let out of jail, and we see this a lot. They don't know when they're going to be let out, and then they're let out, and then there's no plan. So luckily he came to us. No ID, no health card. And so those are kind of scenarios where, because our RAAM, we're well set up to help with the ID, and we can dose the buprenorphine on site, so he didn't have to worry about paying for it for a little bit, because we have our funding included some funding for dosing of the buprenorphine. So we were able to transition him in that interim period where he probably wouldn't have gotten care anywhere else. And I really do think if he didn't, he probably would have fell through the cracks and been back into the drug using and drug dealing and kind of life he was living. But he really engaged with our team, and he's done well. He's gone to 28-day inpatient program. He's done transitional housing, and now he wants to be an addiction worker. So, and I think he'll be able to do it. So that was one that was nice to see, and I think because of the structure that we set up with RAAM, we caught him. He didn't fall through the cracks. Mm-hmm. The existing structure in my community, he probably would have fallen through without RAAM. And another one's more of a very complex comorbidity as far as psychiatric comorbidity and alcohol abuse, as well as opiate use disorder. And it was in the existing framework of OTM-based opiate replacement therapy clinic. And he just wasn't doing well. So he had a worker that I knew in my community, and she suggested he come over to us. And so he did, and we made some medication changes because we were treating more than just opiate use disorder. We treated the psychiatric comorbidities and got him on some different regimens. And he's doing much better. He's engaging. He's getting carries, and he was floundering in the existing system where I don't think there was as much of a connection because it was too much. It was non-community based, it was just OTM based, and so because of our connection with the community and our goal of treating more than just a single disorder, he's done a lot better. So.